Good afternoon. This is Norman Ward speaking. Tanya, are we live now?
We are.
Great. So thank you all for tuning in to Noontime Knowledge. Norman Ward here. I'm the Chief Medical Officer for OneCare Vermont. And we're really pleased to welcome Helen Labun here today to talk about telemedicine and some digital divide type issues. To remind you all, everybody will be muted. If you happen to sign in and find that you are unmuted, if you could mute yourself, that would be really helpful for preventing feedback. If at any time during the presentation you would like to pose a question, please use the chat box. And after Helen's presentation, you could certainly unmute and ask your question verbally or by the chat box. Today's activity is approved for a CME credit through the Larner College of Medicine, and there'll be a QR code at the end for not only an evaluation, but also for claiming credit. So without further ado, I wanted to introduce Helen, who has become really kind of a new friend to me and to OneCare over the last several months with the pandemic. She and I and many others have connected about all things telemedicine over this time period with the pandemic. We have gone from 0 miles an hour to 60 miles an hour in terms of telemedicine. She is the Director of Policy at Bi-State Primary Care. And Bi-State, if you're not familiar, represents the FQHCs in both Vermont and New Hampshire. And something that I didn't know, also represent the free and referral clinics in Vermont, as well as the Planned Parenthood of Northern New England and the AHEC program. Those were entities that I didn't know that Bi-State worked with. Helen has worked for the last couple of decades in rural economic development, including as director of the Vermont Community Broadband Project at the Vermont Council on Rural Development, helping to address rural digital divide across multiple sectors, which, as we all know, has become a very, very hot topic. So next slide. So our goals today are to, this isn't a telemedicine 101 talk. Those resources are well mapped out in some of the references that Helen has provided to us. So if you want to do soup to nuts about how to start a telemedicine program, that is possible with the references that are provided here in the slide presentation, which will be sent to you all. We want you all to understand better how lessons learned in previous digital divide and community development work in Vermont can inform how we should be going forward as we proceed to ramp up telemedicine services, and also to discuss different frameworks for considering how patients who might be reluctant or novices at telemedicine adoption can be comfortable with this option. So, Helen, the floor is yours. I will mute and you will unmute, and the floor is yours.
All right, I will unmute, and I assume someone will say something if you're not hearing me okay right now. Thank you for that introduction. Yes, I've made many new friends very quickly in working on telehealth with COVID-19. As pointed out, this is not the Telehealth 101 talk, but good news, that exists other places on the web, including done by several organizations here in Vermont and also in New England, and you can see some links up there for options if you want to have that broad overview and links to resources, some of which I'll reference in this talk. And if you want it in any sort of variety with focusing on different topic areas, hopefully you'll find the references in these, but certainly anyone feel free to email me afterwards if you're looking for a particular resource that you can't find. Go ahead to the next slide, please. So just to quickly set the stage here, there have been a lot of changes in telehealth in response to COVID-19 that we've all been working on pretty hard for the last several months here, and you see some listed on this slide. The key takeaway, though, that I want to be sure that folks are aware of when you look at these is that Vermont did have a lot of telehealth options prior to COVID-19. People will ask, well, do we still get telehealth after COVID-19? And part of the answer is that there was already a lot of telehealth available in Vermont. There were more restrictions on the federal level with Medicare in particular as a payer. But broad options in Vermont is just that there was relatively low utilization at that time. And that utilization percentages sort of fed into what I'm going to highlight and talk about in this talk, which is a major change during COVID-19, which is that the digital divide became that much more visible, right? When suddenly everyone had to access not just healthcare, but a wide variety of things online and virtually, it became readily apparent just how problematic the digital divide is in our state and nationally as well. Next slide. And when we talk about digital divide, we're talking about 4 basic components, at least for the purposes of this talk. And that would be the broadband infrastructure available, the affordability of the telecommunications plans with that infrastructure, equipment access, and also knowledge and comfort with digital platforms. And these often are treated distinctly with different policy solutions and programs, but I do want to note that they are very much intertwined. And you can quickly see this, right? So if you aren't someone who regularly uses the internet, it has to get pretty darn inexpensive before it is attractive to subscribe at home instead of accessing it elsewhere. So while we talk about these as 4 different components, just note that they are very closely connected when we begin to look at overall solutions around the digital divide. Next slide. Now, I'm going to throw a few stats up here. This is from the Pew Research Center, and these are just to set the stage of telehealth in the broader context of how we live our digital lives. And these are national statistics, but I think they're pretty telling. So the first one here may not be that surprising to everyone. 49% of American adults over 65 don't subscribe to broadband at home. 63% of rural households have broadband at home versus 79% of urban households. And here's where we talk about a rural-urban divide. And just to put a finer point on it, when you look at the number of residential addresses in Vermont that have broadband available to them, and mind you, we've been working on building out broadband to residential addresses for a long time, including 10 years ago with ERA funding. So this has been a long time initiative in Vermont. Only 77% of addresses have broadband available. So even if 100% of people subscribed, we would still not be up to the urban rates. 15% of rural Americans never use the internet. Think about it, never. I mean, we try and spend some time away from the screen, but this is 0% of the time is online. 27% of those over 65 say that they never use the internet. And think about what it would take to get those folks to become fluent internet utilizers, right? Some of them, maybe they will do it just for the sake of telehealth, but usually you're going to need a broader bundle of reasons why. And this is played out in other statistics as well. So as recently as 2015, when we talked to households that had broadband available to them but did not subscribe to broadband, yeah, the top reason why people said was price, but tied with that for top place was that they didn't see it as being relevant to their lives to have broadband at home. So this is an important thing to keep in mind when we think about different attitudes towards the online world and to telehealth. A third point, which I think is perhaps less often recognized, 46% of low-income households don't have a computer. 71% of low-income adults, however, own a smartphone, and that's by individual. So it's more if you're looking at household and you're looking at simply if you have access to a smartphone. And if you take out people over the age of 65 who tend to be less frequent users of smartphones by a large degree, those numbers go way up. There are age brackets where virtually 100% of people have access to a smartphone. Now, the other side of this is 26% of low-income households are smartphone dependent for internet access. And when you look at stats like this, it's important for how we shape telehealth and telemedicine. If a platform is not compatible with a smartphone device, you're cutting a lot of folks out. If reimbursement is not compatible, you're cutting a lot of folks out. when you look at strategies that Vermont has for getting folks access to the internet, we have a heavy focus on fiber to the home strategies. That's really fast internet access through fiber to the home. That is different than how a large percentage of low-income households are wanting to access the internet. So these are important things to keep in mind when we think about the overall digital environment. Next slide. So some measures, obviously we cared about the digital divide pre-COVID-19. It's not just during COVID-19. And here are some options to mitigate the digital divide. And I'm going to spend some time on these because they're still mostly relevant now as well, and things that we should be thinking about. The first obvious one is that it's an opt-in system. Patients who don't want to receive health services via telehealth don't have to. Clearly, the cost benefit on that changed and will continue to change with the pandemic, but it's important to note that this is an opt-in system. Another element is the healthcare practice as the originating site. Now, originating site just means the place where the patient is located, wherever that might be. So right now, for COVID-related reasons, we have a focus on the home as being that originating site, and that was always permitted at the state level. However, federally with Medicare, prior to COVID-19, they did not allow that. Everyone who was accessing telemedicine visits through Medicare was doing it from a physician's office. So at a primary care office, talking to a specialist at a hospital, or at a primary care site, speaking to somebody else who worked for the same organization but was at a different site. So that's another way that we use telehealth and telemedicine. Also an important one that was a heavy focus right before COVID-19 with some legislative work happening in Vermont is telehealth tools that don't require patient participation. These are really powerful tools. Right now, we're thinking of that telemedicine doctor's visit, right, where it's just replacing one-for-one an in-person office visit with a video visit. But a lot of the exciting work in telehealth actually isn't necessarily in that. So for example, it would be an e-consult, which is an interprofessional consultation, if you want the full name. And that's where two clinicians talk to each other. And it's a way to improve the system of primary care and specialist referrals. So I would be a classic example of one element of this. So every time I go to a primary care, I do jujitsu, which is a grappling sport. So I will go to my doctor with a rash and say, is this contagious? And she'll say, I don't know. Here's a referral to a dermatologist in Burlington. And I'll say, you know what? I don't care about the guys that much I'm grappling with. Like, I'll take my chances. They can handle it. A little ringworm never hurt anyone. That's because I don't want to go all the way to Burlington, pay extra money, wait extra time for that, although probably I should have a dermatologist review it. On the other end of the spectrum, there are folks who always want specialist input, no matter what the heck the ailment is. And in between, there are people who really need specialist access, but there's often a long waiting time. So an e-consult system is a way for the two clinicians to talk to each other, often a primary care provider to a specialist, and whatever that specialty may be, pose a clinical question, provide all the documentation and charting, and get the answer back within about 48 hours. And that allows us to keep down unnecessary specialist referrals, and keep access for those who do need a specialist referral, and get people like me a quick diagnosis without having an extra burden on the patient. The patient never has to interact with this system. It's done entirely from practice to practice. A final thing to bullet point here is telehealth tools with a low technology barrier. Again, moving away from our concept right now of those video telemedicine visits. And this could be something like chronic care management, which is a specific Medicare program that focuses on telephone check-ins, or basic monitoring equipment, think like a blood glucose monitor. Even if there is equipment that the patient needs to use, it's something that can be quickly explained and easily explained and is simple to use. So those are all some options for mitigating the digital divide without getting into building broadband to everybody. Next, please. Some COVID-19 responses related to the digital divide. I did not put one thing on this list because I'm not sure if it fully belongs here, but just to be noted in that overall Telehealth 101, during COVID-19, we were also allowing more audio-only codes for telephone connections. But here's a list that I won't go through in detail because that page linked at the bottom is a much better resource than me just talking through it for a variety of programs, either new ones or built off of existing ones, or extensions and expansions for getting broadband access, Wi-Fi access, lower cost plans, removal of data caps, just ways to get more of that infrastructure access available. Next. So those are some, I don't want to say that building out broadband infrastructure is easy, because it is demonstrably not easy, or we would have done it by now. But in the world of digital divide, it is relatively more straightforward than that fourth bullet point, which I believe we're going to need to see a lot more focus on moving forward, which is knowledge and comfort with the digital platforms. And that's what I'm going to talk about next. And just to simplify a very elaborate topic, I'm going to just talk about two elements of it. I could go on for days about it, but we're just going to talk about the culture of tech disruptors and the knowledge of digital natives. Those are two myths that drive me up the wall. So now I can get on my soapbox about it. Next, please. So first off is the idea of disruptors in the tech field. So indulge me while I go a little bit astray from telehealth, but it is relevant in shaping how we talk about, for those of us who have been enthusiastic about telehealth pre-COVID-19, this is relevant to shaping how we've been talking about it traditionally. So a quick definition here. Tech disruptors are people who are making a lot of money for investors by rewriting systems of doing business in a way that can scale to very high volume and revenue, disproportionate to traditional expenses and supplies and labor. I realize this is very economics-y. That is where my degree's in, but I'll give you an example here. Social media and Facebook in particular is an example of disruption in the marketing space. So think about it. When social media entered the scene and Facebook entered the scene, suddenly it was growing not by individuals making sales calls every day, but by friends connecting and connecting to more friends, and memes and cultural tidbits going viral. It was able to expand rapidly and is now at 1 billion people. There was no way you were going to get a message to 1 billion people before we had social media. So that's a classic example of something that was disruptive and in the field of marketing here, using new tools to be able to do things that were literally impossible beforehand. So now suddenly everyone wants to disrupt, right? So an example of this going wrong on the other side is WeWork, which I'm not sure how many people followed their unfortunate IPO attempt, but WeWork was a co-working space with a very hip culture, but they were marketing themselves to investors as a tech disruptor in the real estate space, which they weren't. They were not going to be exponentially scaling in that way. They were trying to build investment structures as if they were, and it did in fact all collapse this year. So we see this happening both ways, in successful ways and in highly unsuccessful ways. Next. Okay. So a certain type of investor wants major disruption because they're taking big chances on a big payday. And that's occasionally amid many, many failures. That is the origin of the idea of the tech disruptor. It began as a specific investment model, but now it's taken on a cultural life of its own in describing all innovation. And you'll see this throughout whatever field you're trying to be innovative in or use any element of technology in. You see the language of the tech disruptor, someone who's going to completely rewrite our systems of doing business. But it's worth asking whether everybody, except for some very, very risk-tolerant investors, want that level of disruption, and especially in COVID-19. Like, didn't COVID-19 disrupt things enough? So telehealth doesn't have to be a brave new world. It can just be another tool that's helping patients solve specific problems. Next. And these are just some images. I Googled telehealth technology and took screenshots of what came up for the images. And this is showing that futuristic new world of healthcare is going to be completely different, whether you want it to be or not. I'm saying we should reject that. Next, please. And here's some specific examples of how we can approach things differently. We can talk about telehealth as a direct solution to a specific and obvious to the patient problem, right? So we have someone with multiple chronic conditions who wants frequent feedback and check-ins with a clinician. That is a common need, commonly identified, not easily created in the real world. Not very few people, not just not everyone, but very few people are going to want to drive every day to a clinician's office, sit and wait, go in for a checkup, and leave again, nor will clinicians want it. But that is something that you can do through a variety of different telehealth tools, from remote patient monitoring to that chronic care program that I mentioned previously, to a whole range of mHealth. There are a lot of apps that help solve this very specific problem. Or someone who should have specialist input for treatment plan, but then doesn't want the extra travel and cost or a long waiting time, right? That was the example we used before with e-consults, a specific pre-existing problem that it can be solved using technology tools. And in this case, without the patient having to do much of anything except for sit back and get their specialist information. So it's a clear solution for me as a patient. We don't need to change the world, we just need to solve my problem. And then another example from COVID-19 is the worried well check-ins, or I would also add to that the insufficiently worried well outreach during COVID-19. And notably, the reimbursement did actually change to accommodate more of these with what were called triage codes. And these are quick check-ins that require some amount of clinical advice. Sometimes they didn't even require clinical advice, it's just easy ways to get your symptoms checked using an algorithm. And this allowed some classic things that telehealth allows us to do. We were able to handle a high volume of interactions really efficiently. We were able to do it at odd hours, depending on what system you were using. And we were also able to use data-driven approaches, right? So OneCare has an example of an application they developed for that outreach side of things, identifying patients who perhaps needed that outreach during COVID-19. Again, a very specific and present and real problem for patients, solvable with technology in ways that non-technology solutions just didn't necessarily exist. Another way we can deal with how we present telehealth to patients in a more acceptable way is the question of how we can practice what's called good website manner. And that's making a video telemedicine visit still feel like a doctor's visit. So folks don't feel as if they're getting less, they feel like they're getting an equivalent value, perhaps with more convenience and less cost. And there are a lot of resources on this question, and that is in the Vermont Telehealth Resource Guide that I linked previously, so I won't go into details, but just to highlight this element of how we think through how we do telemedicine is not as simple as just turning on Zoom and going with it. There is some training that can and should be done for those who are interacting with patients online. Next slide, please. So before we leave the disruptors in the tech field question, I just want to re-emphasize the fact that the way we present telehealth and talk about telehealth is not just a marketing issue. It's an issue of how we're framing what problems our innovations are trying to solve and how the innovation will try to solve those problems. I'm going to say that the problems we should be addressing are ones that our patients have identified, occasionally ones that clinicians have identified, but identified problems that are causing real harm to our patients' access to care, and that the way we're going to try and solve those problems should be as minimally disruptive as possible, not maximally disruptive. So now to another bias that shapes how we frame problems and their solutions, and that's the question of the knowledge of digital natives. Next slide, please. So just to remind everyone that the first computer programmer was in fact Ada Lovelace, who was born in 1815, 200 plus years ago. I'd like to say that 100 years later, my grandfather was born and quickly became the world's first computer nerd. This is not a new world that we are living in. Folks have been working in this realm for 200 years now. Next, please. But of course, right now we're talking about digital natives in the sense of a generation that has grown up with the internet, and we can generally think of as being, quote, good at the internet. But what do we actually mean when we say good at the internet? They're good at navigating the interfaces. So the equipment, the platforms, the websites, that sort of navigation may in fact be intuitive. Another core element of being, quote, good at the internet is understanding research and critical evaluation of information sources, right? The gatekeepers are gone, for good and for ill, around our information. And we see a variety of information sources out there, a variety of credibility of information. You need to be able to understand, to do good research, to do this critical evaluation, to sort through all the problems of misinformation that we now have online. So much more is available than ever was before, but much more that is wrong and sometimes intentionally, nefariously so, is out there. And we see this discussed in a whole realm of different sectors, but of course in healthcare and public health, it becomes particularly obvious and concerning. Another area is understanding how algorithms and the way these platforms are designed will shape your online experience. And this becomes progressively more important the more of your overall life experience is spent online. So for example, we all know, right, that Google shows different results to different people. They do that based on your search history, who you are, what they know about you from what they've gleaned from other sources. It can be very helpful, also very distorting in how we see the world. YouTube is another example. It pushes you through its algorithm suggesting new videos to more and more extreme viewpoints. So you start off searching for healthy cooking tips and you end up a militant vegan, right? It keeps pushing towards the more extreme. And that is not necessarily, they aren't trying to be bad actors necessarily, but it's tied into this fourth bullet point here, which is the psychology of the internet, right? We're building things that are valued by popularity contest. YouTube is pushing people towards videos to get more reactions, get more likes, just create more activity online, and those tend to be the more extreme ones. So when we look at things like community-based healthcare and bringing people together, the last thing we're looking for are tools that are going to push people out to the extremes or allowing folks to go out to the extremes. So the psychology of the internet, as my fourth key bullet point, is, we don't want everything to be valued by popularity contest. I saw an article in, I think it was the New York Times, and I still can't tell if they were putting me on. It was young people whose honeymoons had been ruined by Instagram because they spent so much time fretting about what people thought of their pictures on Instagram. I gotta tell you, like my honeymoon, I cared what I thought. About 80% of me cared what my husband thought about what we were doing, and I didn't care what anyone else thought about what we were doing, right? So this is a very different way of seeing the world. There's also another common example of the psychology of the internet is the habit formation elements, right? Those dings, those announcements, those buzzes, those reasons to keep clicking on whatever app it might be. Again, sometimes used in a good way, maybe getting people engaged in exercise, for example. That's a classic way in which they're using habit formation to form good habits. But again, we need to be aware of these different elements and be sure that the tools we're building are solving problems, not creating problems. And of course, folks working in mental health are particularly concerned with this element of it. So here's some ways that we can think about what it means to be, quote, good at the internet. And I ask you whether this really describes everyone born after 1995 just naturally. It doesn't, right? We need a range of perspectives in how we shape our telehealth future. Next slide, please. So one area where we do see a pretty heavy difference based on age is in that question, the first bullet point of the ease of navigating interfaces. And that's particularly the much older generations who aren't using the internet as much compared with the younger ones. So often we say, well, we'll get digital native to explain how to use Zoom, right? So, but I want to point out that as we set up these systems for helping, there are some other things we need to think about. The first, and hopefully most obvious one, is how many interfaces are accessible just in general, right? You're looking at, do you have enough contrast in the fonts for people who may not have that great vision anymore? Do you have the dexterity to navigate drop-down menus? There are some that I can't even navigate correctly. You have to be a Nintendo master to make these work, and I don't have arthritis in my hands. I have up here a link to a website that has some examples of accessible interfaces. Next, please. And here's an example of what I mean by we aren't doing enough to make the digital world accessible. This is my own guide to telehealth resources. I could not figure out a way, because there was no way, to change the default format for that little thing in the corner, the little hamburger symbol, which is the symbol that you click on to show the menu. Now, that is hard to see. And who would intuitively think that you need to click there to see the menu of sections? Nobody. You see less of these now, but this is a prime example of whether or not we're actually developing an accessible online world. Next slide. Now, some other elements to think about as we set up our systems for explaining the different interfaces. There's a training in how to explain the platform in a way that can be retained for the next time. I think we've probably all had this experience, right? You're trying to explain how to navigate a website. You're not naturally great at explaining things, and you quickly just default to, you know what, I'll navigate it for you, right? So there is an art to how to explain this, and it comes particularly challenging when you're explaining it to someone who does not frequently use the internet or navigate these systems, because it becomes that much harder to retain it the next time. And in fact, when we worked in Vermont, we often tied explaining, for example, how to navigate a website for accessing government benefits to a broader digital literacy goal of getting people to simply interact more with the online world, because that was the way they were going to retain this information. And then the third bullet point is the effect of reinforcing an older patient's self-image of being tech incompetent when they are paired with a much younger person who perhaps isn't explaining things as clearly as they might with a website that is not designed with accessibility in mind, right? And it becomes a self-fulfilling prophecy. And there was actually some really interesting research done by a researcher named Sonia Lupien up in Montreal. She studied stress. I found this really interesting. She was going back and looking at studies around forgetfulness in seniors, comparing them with college students. And the basic observation was that she had been around college students. College students were forgetting things all the time, class assignments, whether or not they had an exam, what they did last night. And she was going back to the different experiments that her college had been running with, I think it's 70-plus-year-olds versus 20-somethings in forgetfulness, and realized that when you did those experiments in the older subjects' home court, like at their house or at a senior activity center, they did just fine on those tests. What those tests were really measuring was how much the older generation hated showing up on a college campus and racing 20-year-olds in forgetfulness tests. When you took out that element, everyone performed the same. So these become self-fulfilling prophecies that we need to be aware of. Next slide, please. So as with the disruptors example, it's not just a superficial problem. We're getting hung up on navigating equipment and interfaces and emphasizing an element of telehealth that has a strong age disparity. So that's a roadblock that's standing between us and engaging patients of all ages and backgrounds and thinking through whether telehealth tools might be the best solution for specific problems that they are identifying in healthcare, right? Getting back to that tech disruptors, how do we reframe this and how we're approaching telehealth's role in healthcare? We can't get hung up on things like ridiculous interfaces that no one can navigate to keep us from getting to the more substantive questions at hand. Next slide. So a quick rundown here. What would telehealth look like if it were designed with the digital divide in mind? And we've got some starting ideas from this conversation, right? So there's the basics of the infrastructure, broadband infrastructure, assistance affording subscriptions, the equipment to access that broadband. We've got looking at telemedicine that can work across multiple devices, especially smartphones. We have the world of options that don't require the patients to be the ones navigating those online services, things like the interprofessional connections, the e-consults that happen at the clinician level. We have options that use the telephone or that are blending in simple technologies that don't require broadband, they don't require a lot of web navigation. There's a lot of technology out there, let's use it. There's de-emphasizing disruption and instead focusing on direct solutions to common problems, particularly ones like the ones in those examples I gave that don't have a strong non-telehealth solution, ones that are going to rely on us eliminating transportation barriers, handling high volumes of inquiries, doing things efficiently behind the scenes so that the patients don't have to engage with them. There's the clinician training and how to interact effectively with patients online. And again, there are lots of resources online for that and training programs that are set up. Training in how to best provide that patient support to getting online and getting connected and how to do that in a thoughtful way that it actually can take, right? And then, of course, fully accessible websites and telemedicine platforms. So here's some of the options that we know right now. But there's also, again, the bigger takeaway that I keep coming back to is that we're not really going to know the answer to what telehealth looks like if it's designed with the digital divide in mind until we've built those frameworks that get rid of some of our less helpful myths and engages everyone in designing what it should look like moving forward. So that's the key takeaway I want you to bring from this. And I think if I say next, it will be the last slide. And it is the last slide. So that is a quick intro to digital divide concerns and telehealth. I know it's a big project to work on, and I've just tried to give some ideas and perspective there. Happy to take questions and comments and thoughts on that, but also, although I dismissed the Telehealth 101 stuff at the beginning and gave some links there, certainly happy to take any questions that I may or may not know the answer to around telehealth deployment in Vermont.
Thank you very, very much, Helen. This is Norm. So the chat box is.
Oh, Norm went out, but I think he was telling you to enter things into the chat box, which I can see on my screen, so I'm able to respond.
So this is Norm. I did have a question about senior centers. Are you aware that probably with COVID, many of the senior centers have shut down and not, educating seniors who may have in previous times frequented those centers. Is there, to your knowledge, a online or other alternatives to what we used to know as bricks and mortar senior centers for training such as this?
Right. Well, and there's two sort of interesting problems in there, right? So senior centers, libraries as well, are places that we've previously turned to in terms of helping with online access and some amount of digital literacy. That works well for generalized access and some things you want to do online. Not so great if you're actually having a doctor's appointment, right? Then you want privacy and you don't want to be in the middle of a public library or a senior center necessarily. So there's sort of two problems inherent in there. And that's one that I know needs to be solved. I am not aware of an online system for helping with the broad digital literacy. Then again, I've only been looking for like consulting groups that you can call for particular help setting up a telemedicine visit. So just because I haven't seen it doesn't mean it's not out there. It just hasn't been part of my research. There's a question here about smartphone use, and it favors the use of apps, but not all practices may be using the same apps, if any. This will be a problem for patients that see more than one physician. So that's not just a problem with smartphones. That's a problem with all platforms because a different practice may be using a different platform for their computer. I will say, actually, OneCare did, well, two things. First off, I'm going to get a little bit wonky here. At the beginning of COVID-19, we, the Office of Civil Rights federally, it wasn't we at all, waived enforcement of HIPAA compliance. Oh, I see Mark has a question that he lost audio. Can other people hear me?
Yes, Helen, we can hear you just fine.
So I'll give the answer. All right, other folks can hear me. So a key thing that happened at the beginning of COVID-19 was waiving HIPAA compliance for platforms for telemedicine. Those are the video visits. And that was done so that it was easier to use applications, platforms that were more familiar to everybody. So that, to try and lessen that barrier for getting online. So and OneCare did a great survey at sort of in the middle of COVID-19 shutdown in Vermont to figure out what different platforms people were using. Generally, and in this survey, far and away, the most popular application was Zoom for doing the video visits. It's the most familiar one broadly. And it also has a healthcare version. You can get HIPAA compliant Zoom. So you can be set for healthcare both ways, right? And I believe that was around 75% of practices were using that. It was not differentiated, the HIPAA compliant version or the telemedicine design version versus just the popular version, but that was significantly the most popular one. FaceTime was the second most popular, I think followed by DoxyMe. DoxyMe is a telemedicine specific one, not to be confused with Doximity. There is a lawsuit around that. Those are two different platforms. FaceTime, however, is not. So at the end of the COVID-19, there is going to be some amount of shuffling as to who's using what platform. And this is for those telemedicine visits. But that being said, there are popular platforms out there that will look familiar to patients and how they navigate them. The other thing I would add on those platforms is I just saw across the telehealth news this morning the idea that we're continuing to work to have something of a tech fix to the confusion of navigating platforms, right? And some of this has to do with accessibility. I don't know about you, but my Cisco WebEx default has itsy bitsy font that I can barely read on it, right? So having a default to larger font would be an example. Captioning systems are often looked at for how well the captioning systems are working. And then what was across the screen today is just simply making simplified applications where you have minimal bells and whistles. Also from the provider side, they often include things like signing patient consent and being able to do that easily online. So there's a lot to be said for using a platform that's designed for the purpose of telehealth. Can you educate the audience about current limitations on FQHCs and telemedicine, especially with Medicare? What time is it? It's 12:40. So federally qualified health centers. So it is ironic that I, working for the federally qualified health centers, am a big telehealth enthusiast because traditionally federally qualified health centers were cut off from providing telemedicine services. And by telemedicine, I'm talking about what we're thinking about traditionally with those office visits, the video visits replacing the office visit. So Medicare, which is a fairly large percent of our payer, and we serve 38% of Vermont Medicare recipients, did not recognize federally qualified health centers as providers of telemedicine. If you want to get jargony, that's called being the distant site, the place where the provider is located. So we were not recognized as providing that telemedicine, which unfortunately, although some of us did have some pilot programs and work happening in that area outside of the Medicare population, Rutland, for example, had a great pediatric telehealth project going to connect with schools. We had not had a regulatory or policy framework in which to develop great telemedicine programs prior to COVID-19. This was waived temporarily during COVID-19. Unfortunately, it was waived in a very administratively confusing way, and additionally at half of our normal rate with a large and previously unapplied copay on top of that. So the economic system for FQHCs in Medicare is really bad. There's no way to say it. Like it's a terrible system for FQHCs, and particularly difficult when you look at this particular time where you are not yet in the trajectory of telehealth or telemedicine saving money, right? You in fact need to do more work to get beyond that digital divide, more work to get patients engaged, more work to make sure that they're truly accessing the telehealth and telemedicine services they need. So it's a significant increase in costs, plus the clinician training, the setting up the platforms, all the things that would go into that and doing it right costs a lot more while we're being paid half of what we paid, and many of us haven't been paid at all because of how the administration worked on it. So it's really, I have nothing good to say about it. Zero. Is there a cheerier subject in the chat box than that? Here's an adult daycare. So I'm going to read from Kristen at Elderly Services in Middlebury. They run an adult daycare without walls during COVID, but it's just during COVID. They spent an incredible amount of time getting about 85 participants on Zoom for their therapeutic activities program. She's wondering if we could help people figure out how to be more comfortable in a telehealth visit. Do I have recommendations of a resource we could use to run a training session? Yes, there are resources online, and actually Netric, which is one of those links at the beginning, does a great thing. They do webliographies, they call them, with lists of resources, and that's one that they have a list on. And I can get connected with you after and share that information. Phil is asking if we need to look at malpractice in a different way in the telehealth realm. I am not a lawyer. So what I'm about to say about malpractice is not legal advice. I will say that there are two elements where this generally gets talked about, at least in my hearing, in my non-lawyerly hearing. One is in the area of providing telehealth across state lines. So the place where medicine is being practiced goes with where the patient is located, not with where the provider is located. So if you're a provider in Vermont and you have a patient who was in New York and used to come across to your Vermont practice to see you, if you are not licensed in New York, normally you cannot provide healthcare services to that patient in New York, even if it is an established patient who you would normally see in your Vermont offices. During COVID-19, individual states waived that. This is a state-based thing. This is not a federal thing. So that got cleared away during COVID-19. Is a robust discussion right now how we manage that leaving COVID-19 to engage, to keep continuity of care for patients using telehealth. And that's a very complicated topic. So that's one area where this comes up, is where you're actually licensed to practice medicine in the somewhat borderless world of telehealth. The other area where it comes up is in the question of, and this is clinically important, that when you are providing telehealth services, the standard of care does not change. This includes audio, visual. So you are meant to be providing those services when you can reach the same standard of care that you would be providing in person. I am not a clinician. I do not do clinical quality. I cannot help anyone on how they reach that standard of care. Luckily, VPQHC is doing a project on this and looking specifically at audio only. So look for that as well. So that's the other area where you often hear about that question, is in that standard of care issue. If time allows, can you tell us more about the Rutland Telehealth School program you just mentioned? I actually do not know what they are doing this year, so that is a good call. I should check in with them. I will say that I knew they were about to expand into teledentistry, which was making everyone really excited, and I would love to know if they in fact managed to do that. But you do see, just broadly speaking, I can say, in school programs, this is often an application of telehealth, because you can get a school nurse set up with different equipment and to be able to connect with someone. And then, like, think about a patient, right? If you're able to connect with a doctor with a kid at school who's sick with, I'm not a doctor, I'm going to make something up, an earache that needs medicine, because I hear that happens a lot with kids. And you've got someone with an otoscope, and they make these at the school, who can send that to a doctor. The doctor can diagnose, send in the prescription. The parent can get the kid, get the prescription, and get home without making 5 different trips around it, right? Another thing that Rutland was looking at was and how they could serve camps, for example, to have ongoing access to a clinician from a summer camp. Dr. Schneider is the one who is running that work in Rutland. I'm sure he'd be happy to talk more about it. I should say, I don't know if Rutland was doing this, but often you hear about it also with sports, being able to have a clinician available in some way at sports practices. Having well, you know that I do jujitsu and I did wrestling in high school. That would have been awfully convenient back in the day. I wouldn't have broken my nose without realizing it quite so many times if there'd been any consult there. Comments on how to include residents and medical students in these encounters from your experience and review of research. I don't have any comments beyond the fact that you should talk to UVM Health Network because my members don't deal as much with that. It hasn't been an area of topic for my work. I do know that CMS has created more flexibilities for virtual engagement with residents and medical students. So that is an area that's being discussed. That just isn't one that I have been involved in. The crazy situation concerning smartphones as video-capable devices for the future of telemedicine services. So this is going back to my earlier comment about smartphones matter. So this is if you really want to get into the Byzantine structure of federal telehealth regulation. CMS, which is they're the folks who set the rules for Medicare. They also influence Medicaid policy, although that has more state control. It's not fully federal. And actually, we've got 10 minutes, so I can broaden this out even further. I'm going to take this a step broader here. So when we look at exiting COVID-19 and the policy changes that need to happen, there is a lot of confusion. And this actually, I do break it down a bit in the telehealth boot camp that I linked at the beginning. So when we look at how we change flexibilities to make the ones that we want we don't want all of them, but the ones that we want still available leaving COVID-19, we have to make a distinction between what's controlled at the state level and what's controlled at the federal level. And then what's controlled in statute versus administrative rulemaking. So what Congress can change at the federal level, what Congress can change versus what the Department of Human Services can change. And there's a lot of confusion around that right now. So the problem that I was talking about for federally qualified health centers, for example, not serving as distant sites, that is controlled by Congress. So you need an actual act of Congress to get that to change. So right now, federally, there's an argument going on between presidential executive orders and Seema Verma, who's the administrator of CMS, and Congress trying to sort out who can actually expand what in terms of what we can do for telehealth. And one area of question when we look at the availability of different codes is that one gray area is the control of what devices that can be used to access telemedicine. So right now it's written into the Federal Register, which I believe means a variety of people could change it, but it takes a lot, that you can't use a telephone with audiovisual capability. This is at the federal level, so we're not talking Vermont. Vermont's very understanding of things, but at the federal level, whether or not you can use a telephone to access telemedicine, even if it has audiovisual capabilities. So as we look at questions like whether audio-only codes can stay, we also have questions about who controls what device you can use. And that gets into Federal Communications Commission, a lot of different regulatory labyrinths, which is just generally to say it's going to be really complicated how we sort this out. So one of the goals federally and in policymaking is to build ourselves as much of a runway as we can get after the end of a public health emergency, which is what's currently keeping all these waivers in place, as much of a runway as we can get to sort this all out so that there isn't a gap in continuity for telehealth services to any patient in between the two, because that will be a big problem if we move backwards before we move forwards. So everyone who does not do policymaking can be glad that they aren't involved in those fights directly. But we appreciate any support that's available. And Kristen is going to follow up. Kristen, I will follow up with you. It will be a great conversation. I'll be excited to hear what's happened.
Helen, this is Norm again. I was going to type another question, but in your understanding, if we as a society tried to calculate the cost of expanding access to broadband by way of hooking up houses versus building out cellular technology, have you heard estimates of, is it 1-to-1? Is it half as much to build out cellular compared to hooking up houses to wires? Have you heard that figure before?
Well, part of the problem is, and the reason why Vermont has such a focus on that fiber to the home 100, or it's also you hear it as 100 service or 100 symmetrical, that's the speed, is that because the capacity that we need to run these services keeps getting higher, that if we don't build out at the highest available capacity now, that 10 years from now, it will be too slow, which is, you know, a race that you'll keep losing, right? So it's actually a much more complicated question than that, because you have to build in that time element and how far out you want to go. So for example, when we got the CARES Act funding into the state, that had a time period built into it. It said you have to build out what's minimally needed to access telemedicine today with the service types that are used today, with the availability that's today, which is why you see very different things happening with that money in the state of Vermont than you would with any other money, because Vermont has built in, it's not that they're doing a one-to-one comparison of cost right now, it's that they've built in a specific time horizon looking to the future for when they want to do those numbers. So that's why it's built the way it is. And it's a complicated problem, both economically and in a policy sense.
I really appreciate your insight into that, because, I mean, DSL is probably too slow also for a lot of people's future needs, but would be perfectly serviceable today. So that people with landlines, if they had enough money to be able to afford having a landline, would at least have adequate, video capability by DSL.
Yeah. And I should say, when we look at telehealth delivered during the time of COVID-19, it's also a distorted view of what you need, because there's a lot more happening online in any given home than there might otherwise be. Because maybe you have someone accessing work online, accessing school online, and accessing telehealth online, and they're doing it in the format of a telemedicine video visit, right? All those people with so much demand in one location wouldn't necessarily happen during a more normal time. So there's also another thing to note in terms of looking at this. And if you go to that Department of Public Service link that I put up there, you'll see they have some guides to how to manage those types of issues that we're beginning to hit, even with people who previously had adequate access. So there's another thing to note there on the speeds. No, never mind. The question was answered. Slides used in your presentation.
Helen, there is one there about the storage.
Yeah.
Materials. Is there any current policy on the ability of recording telemedicine interactions and keeping them?
Right. So that's where, again, with the caveat that I'm not a lawyer and other lawyers could correct me, but that's where HIPAA comes in. So that's a legal framework that's built to ensure that you don't have issues with private sessions being stored and then going out to everyone. We do actually there was a telehealth office hours with VPQHC where we went into more details about different technologies, have different ways of packaging things to get from one point to another. And could it be technically feasible for someone to steal it in transit, that kind of thing. So there is that more technical conversation. Legally speaking, HIPAA is there to prevent that. Now, there may be applications, things like there's an area called mHealth, which is mobile apps for health. So if you think about like a Fitbit or a fitness tracker type thing is the non-clinical version of it, where the intent is to store some record, or things entering into an electronic health record, and those being shared in, say, the e-consults with a clinical consultation. There are lots of things where the idea is that you will store it and you will have a track record and you will be able to refer back to it. So there's a wide range of applications where, yes, that's the intent, is that things would be stored. But HIPAA is, in the sense that I think Phil means that of sessions being go into the web, that's a two-part question. There's the technology issue, and then there's the HIPAA issue that's designed to guard against that. Yeah. And if you can't get enough telehealth conversation, I will note that NETRIC, VPQHC, and Bi-State have been doing, first they were twice a week, now they are once a week. They're about to, I think, get a little bit less frequent than that, telehealth office hours that have covered a wide range of different topics. And in that original set of links that I showed, it included a link to where you can go to get both past recordings of those and to sign up for future sessions. Definitely show up to the one this Wednesday at noon if you have time, because that's where we'll be discussing what they're going to do moving forward and any topics that we haven't covered that folks want to see covered. So if you want to be part of those conversations, definitely noon on Wednesday is the place to virtually be.
Well, Helen, thank you so very much for your expertise and willingness to take a crack at lots of questions. If people have further questions, they can get them to Tanya, and we will forward them on to Helen. Her work is never done. Once again, thank you so much. This is the future of medicine, and it's a very exciting time. And so, everybody have a great afternoon. See you later.